Hello, everyone. Thank you so much once again for joining us at the Voices podcast. My name is Arafat. Today, we are honored. We have a special guest in our studio, and we have Professor Stephen Rulisa in our studio. He is a renowned obs gynecologist in Rwanda. He is a consultant obs gynecology in the country. He is a professor of obstetrics and gynecology at the University of Rwanda. So, and of course, he's a renowned researcher in this country in the same field. So today he joins us to delve deeper into the conversation of maternal and child's health in Rwanda and to get a deep understanding of where we come from, where we are now, and where we want to go. So, thank you so much, Professor, for joining us today in our studios.
Thank you.
How are you? How are you, Professor?
Good. Doing well. Thank you.
How is life? How is life?
Life, mine is always very good.
You're very fine.
Yes, very.
Okay.
Yeah.
So, someone who has just seen you right now, how would you tell this person who is Professor Rulisa if you were to talk about yourself in just 1 minute?
A Rwandan, a healthcare professional, obstetrician, gynecologist, and a researcher involved in reducing maternal mortality and improving maternal health in general.
Before we go into today's conversation, what mission are you right now on in that field of maternal and child's health?
Reducing maternal and child death.
It's what you're focused on now?
Yes.
Okay. Is there a simple way you would tell us what you're doing now about that?
So, for many years, I have been doing that as a clinician, treating women and the neonates to reduce mortality, fighting infectious disease and causes of maternal mortality. Now I am trying to advise and doing research using evidence-based data to improve lives, especially at the policy levels, and generating data that can be used. So that we cannot afford anymore to just do things without evidence. So I'm trying to generate real-time data that we can use to make policies to improve lives.
Oh, wow. That's really wonderful. So you're more in researches now?
More in researches, yes.
Okay. So my first question today, I would love to ask you about, as someone who has been on the front line of maternal and child health in Rwanda, I'm sure you've been in this field here for, I think, over now 2 decades.
Yes.
Am I wrong?
Yes, that's it.
So
more than 20 years.
More than 20 years. How would you describe the journey? How would you describe this journey right now? I mean, where are we coming from? Where did you find it? And where it is now?
Well, I think I can say it's one of the most interesting journey. When I started as a doctor, before I even became a gynecologist, it was one of the most scary and most interesting job. There has always been too much to do and too few to do the job. There were fewer doctors in this country. Mortality was everywhere. Morbidity was everywhere. And everything you do, however small, would make a huge impact. But I have seen tremendous improvement in health sector, specifically. I mean, in this country, everything has changed to better, but I will speak about health is what I know best. There has been a significant improvement in all indicators, especially maternal and child health. Yeah. So it has been an interesting journey.
So, I mean, let's have an example of one patient. Let's say in 20 years, what is it that mothers were not accessing or children were not accessing that you would really appreciate that today we have ABCD in that field?
I would give you an example. 20 years ago, maternal mortality, how we calculated the number of women who dies per 100,000 was over 1,100. And now we are almost 100.
It was over 1,100.
Yes, and now we are almost 105 and 7.
But still,
thereabout.
okay.
It means you have reduced 90% of mortality. 90% is a significant decline. I don't know anywhere else in the world where that decline has happened over a short time.
Oh, really?
Yeah. So 90% reduction in this is a huge amount of reduction in maternal health. Child health is the same, and then several other indicators. So it's a tremendous decline in maternal mortality and morbidity.
So what is it that you can really say that this is what led to the reduction we are seeing now, that is visible to everyone out here?
What we have done, there's not one thing you can point a finger, but several factors come into play. Number one, you can say, I told you, I now I do a little bit of work assessing policy levels, comparing countries and performances. I can say what has been unique in Rwanda is leadership. Leadership from the top has been engaged to see these things happen. Now, when you have leadership that is driven by data, that is questioning why things happen the way they happen, and they're always challenging the status quo to want things to better, it's one of the most significant factors. Of course, number two is increasing the number of healthcare professionals, increasing health facilities, which means bringing services close to people. If a pregnant mother used to travel 10 kilometers or 15 or 20 kilometers and only to find one nurse, now they can walk a few kilometers, maybe 3 kilometers, and they reach a health facility, and there are medications, and there are doctors, and there are ambulances to transfer them to the nearest health facilities. There is technologies to enable all this. It's a whole ecosystem that has changed and enable survival of women and children.
So it's a combination of many things that you cannot just say that
you cannot
ABC,
point on one finger, but the driver, I could say, is leadership that has been enabling all these other factors to come together.
But you said 100, so far it's 100 per year. Is it per year?
107.
Per year?
Yes, yeah. Per
Death.
100,000, yes.
Per 100,000 mothers that give birth.
Yes.
But this number, according to you as an expert, I'm sure you might be having a blueprint of what do we need to do now, this number to go off to? Because 100 is also a good number. I mean, it's not, compared to the research, as you said, might be considered a small number. But
correct, of course.
What can we do at least to have 100 also off?
We need to double our effort. So I would tell you, like when we began, every minimum effort that you do would yield significant results. If I put a medical doctor, if I'm in a health facility, I can save 20, 30 lives. Now one doctor cannot do that because as the numbers come lower, you need a tremendous amount to reduce even one figure. Now, epidemiologically speaking, if, let's say, $10 saved 20 lives, now $10 may not even save a life because the situation has changed, because the numbers have become more remote. And so you need to apply more effort and more technologies and more wisdom.
What do you mean the numbers have become more remote?
Okay, let me give you an example that you may understand if you come from a rural area like me.
Okay.
If you pick mangoes in a tree, a mango that has 1,000 fruits everywhere, you just need a minimum effort to just pull a mango. You can even shake a tree and all mangoes fall down, right?
Agree.
But if these mangoes reduce tremendously and you remain with fewer mangoes on top of a tree,
you need to climb it.
You need to climb, you need to throw stones, you need to call more people to... So you need more effort to just access one mango.
Wow.
That is what happened. Before, it was rampant. Death was everywhere. Any minimum effort...
So you would pick around and get people to treat and get people to work on.
One nurse would save 10 lives. But now, people are educated. Now diseases are more complex. You need a lot of effort. That doesn't mean that we have to stop, but it means we have to employ more wisdom. This is why we need more specialists, more subspecialists, more technologies, more equipment to keep the rate going as down as we were doing. So it requires more effort.
So to make someone watching this understand it clearly, it's like, let's say if you are concentrating more on in urban areas to treat people, now you need to go like to Nyagatare,
Yeah.
deep down in the villages,
Yes.
to get this person also access the same services.
Yeah.
And of course, I can see that the cost from here to go and access service to get services to someone in Nyagatare is very costly than giving someone here.
Yes.
That's what you're saying.
Yes. Yes.
Wow.
But now what you need, of course, is employ more measures, which means enabling technologies, use technologies, access transport, make sure there's hospitals or health facilities are more equipped, and make sure there's timely delivery of services to these people who need it.
Okay. So another question, what are the most common preventable complications you see among pregnant women in Rwanda, and how can we better tackle them at both the community and policy levels?
The known cause that has never changed for many years is postpartum hemorrhage. It means bleeding after giving birth. Women bleed after giving birth and they die.
Does this happen still in the hospital or
It
after
still
they leave the
happens
hospital?
everywhere. It still happens everywhere. But if the women deliver at home or in a very lower health facility, it becomes more complex because you may need to use more advanced techniques, if I could say. So it means it is the number one killer of women. If you take that off, you take like maybe 60% of mortality
Really?
in our country.
So you mean if we can manage that, we can
manage
reduce 60 women,
yes.
60 women
Yes,
that
yes.
die out of 100 that we talked about earlier?
Correct. So you need a lot of effort to do that, and you need to educate women to come early. You need to educate them to deliver in health facilities. The beauty of this that is it doesn't require a lot of technologies. I mean, more than half of this can be fixed by just your hands and your knowledge, knowing what to do, knowing how to intervene early. You can save more than 50% without using any medication. Now, if you add any medication, is one of the cheapest medications we have, so it's affordable by anyone. So if we have this medication in the health facilities and we have a trained healthcare professional, they can reduce postpartum hemorrhage easy.
Oh, wow.
So that is another low-hanging fruit we need to do.
Why are we not doing it? Because you said it's easy
We
to
are
do.
doing, that's why we reduce from that number to this number, but we still have to maintain it. Now, the question is if we have to make sure that 100% of women deliver in a health facility. That's now beyond healthcare professionals. If they deliver in a healthcare facility, and if the doctors can anticipate it and then act in time, then we can still do. What we are doing now is to train every healthcare professionals to know how to anticipate it. In most cases, when it is detected late, then controlling it becomes a problem. And so you want people to anticipate it after delivering a mother. You've got to anticipate it, and you've got to put up all the measures and measure the blood loss accurately and make sure you can know, oh, this blood loss is more than they expected, and then you start intervening at that time.
Give a hint to someone seeing you right now, a fellow doctor, or who are these people who help mothers to give birth called? Remind me. It's,
Midwives.
Yes. One of the midwives that might be watching us right now, how do you anticipate? Can you give a hint of two, three things that someone
is
can...
that when we grew up, when we trained as junior doctors, we were told bleeding more than 500 cc of blood loss is more than enough, so it's postpartum hemorrhage. The question has been, how much is 500? How do you measure 500?
How do you measure that?
Yeah, so people would just watch blood on the floor, or you see a bed sheet, how much is soaked, and you say, I think this is 500. Now, studies have shown over 70% of healthcare professionals, including gynecologists, make it wrong. They can't estimate
They make a wrong judgment
wrong judgment of that blood loss. I mean, someone bleeding, moving from a bed to another, you can't visually anticipate and expect the amount of blood loss. So we just have to see. The other way of detecting that has been just to, as a clinician, we just look at a doctor and measure pulse rate and see the hemoglobin level by just conjunctiva and so on, and just, I think you lost a lot of blood. Now, that is not efficient. Now, studies have shown with high level of statistical significance that you cannot anticipate that. And so we came up with drapes or bed sheets or kind of a plastic that is marked, that you can measure every drop of blood. And so that is what we should use, calibrated drapes. Is put on the bed, and every drop of blood that comes out after delivery of a baby is measured. And therefore that 500 can be accurately measured.
But
so this is what we recommend to
I've
do.
not seen them.
It's very new.
I've not seen them
I'm
around.
traveling all over the world now to make sure people know this. The studies were done now few years. Problem is that people have to know and use them. And people have to acknowledge that their visual inspection is not accurate enough. So they are now available. Countries are using it. Rwanda is scaling it up in all, not yet in all health facilities, but that's the move to make sure.
Have we scaled it up? I mean, do you have
We are
some
in the process of
examples
scaling
of
it. They are
hospitals?
in the country now.
But not yet in hospitals.
In some few hospitals they have, but not all health facilities.
Oh, okay.
But I guess by end of this year, every hospital should have these calibrated the drapes. And then also the way we so if you know that, and then you start intervening. Before, you would start with one medication, let's say oxytocin, and then tranexamic acid, and then carbetocin. So you keep using one drug, wait for some time, it fails, use another one, wait for some time, it fails, use another one. Now, evidence shows that you've got to put in this drug at the same time. As long as you find this blood loss significant, some people say 300, some people say 500, whichever way you decide, you put this medication in the mother as soon as possible, and it yields tremendous results. Now, what we are training people is now to adapt this way of reducing postpartum hemorrhage.
Okay, so that is on a phase when a mother is still in the hospital.
Yes.
So I want us to speak to a mother who has left the hospital, and after reaching home, this happens. Postpartum hemorrhages happen.
So
and then how do they know? How do they resolve that?
What we wanted to recommend is that women should at least be observed for a minimum number of hours, depending on how the facility can accommodate people. Maybe 8 hours, maybe 12, maybe 24, observing the women. Now, if women leave the hospital, the key factor is education. You've got to educate these women and tell them, should you see any bleeding more than this? Because you're saying you observed them, let's say, for 12 hours, and say, if you bleed more than this blood that is coming, come to a health facility. Don't try to do stuff on yourself. So education, again, is key for patients to know how to detect this. This is part of the training that we have to inform our healthcare professionals.
So you hope to do that too, or you're doing it already?
We are doing it concurrently.
Oh, okay.
Yeah.
That's wonderful. So there's a growing conversation about integrating modern technology and digital tools in reproductive health. How do you see that playing out in Rwanda, and what's still missing?
When I travel the world and visit different countries, I can say that Rwanda is doing very well. One thing I can say about embracing technology, that the technology is here, is not going anywhere. Whether you admit it or not, it is here. Now, we have to embrace technology, and it is an enabler. Everyone has to embrace technology and use technology. It makes our life easier. Now, in future, technology may replace some people. The good news is that it will not replace you if you embrace technology. If you embrace technology, it becomes your enabler. It makes your life easier. And if you resist it, it will replace you in the future. So I encourage everyone to embrace technology, use technology, and as an enabler. AI is coming. AI is much smarter than most average people, and is going to make life much easier. So I think we should embrace the use of technology.
In your field of obstetrics and gynecology, let's be specific on Rwanda. what kind of new technology do we have so far that are you using now in your
Oh,
field? Like one
we
or two,
have a
three
lot of
things.
them. Some of them is in communication. For example, you have heard about sending SMSs to mothers. You can, let's say, if a woman comes to a hospital and they see she's pregnant, number of weeks, and maybe she's high risk to eclampsia, diabetes, all these, or maybe preterm delivery or something. And then you can put in your system and you can say, if you have this and you have this and you have this, it will trigger a certain color red or something if you have ABC symptoms. And then a community healthcare worker can just trigger a symptom and say, this is red. And so it means this woman is high risk. I need to transfer her to another level that is beyond me. That is technology, because anyone who is not a doctor can just pile up things and say, do you have headache? Do you have dizziness? Are you feeling weak? And so if I look at my paper, if you have 1, 2, 3, 4 symptoms or signs, then you become a high risk and you transfer. This is using technology.
So this is happening in
This is happening,
hospitals.
yes, in communities,
Oh.
so that patients can be scaled up to hospitals and be attended to. We also have e-health, whereby maybe in a rural area, a healthcare professional, a junior doctor or a nurse can use, let's say colposcopy, for example, which is AI enabled, and you look at something, you don't know what it is exactly, and you can transmit the image to someone superior to you in a referral hospital, and can look at it and help you to make a diagnosis without transferring these things. It's used in laboratories, someone in a pathology lab or just a general lab technician can use it and can send this message. We are soon introducing AI-enabled ultrasound. It means anyone with basic minimum knowledge can just put a probe on someone's tummy and just rub like this, and it gives you everything. It says, this one is pregnant, 20 weeks, baby is gross restricted, you need to refer. So you don't need to have a high-level training of ultrasound, and you just do that. So this is because of AI. This is because of technologies that can do this.
Where do you see the future of maternal and child health in Rwanda? Like, I mean, what would you tell young doctors, young emerging doctors in this field, what they have to put their focus on mostly? Because, I mean, you're in research right now. It takes you a lot of time, and that simply means in your consultation room there's someone you've left there. I mean, there's someone who is now taking over your position that
Yes.
that probably needs your skills.
Yes. Yes.
What would you tell these people? I mean, speak to them. Speak to someone who you leave in your position in your consultation room, what they have to do.
That's what I always wished, to have many people who can replace me and who can be actually smarter than me and do much better. The thing is that I tell young people that you may have challenges, but I call perceived challenges you think you have. Most of them are just perceived challenges. But what I want to tell them is, wherever you are, always know that you can make a difference. You have to believe that you have to make a difference. And number two is that always do your best. And that is all we can do. You can always do your best. And you just remember that it's, at the end of the day, what counts is the result. Have you made a difference? Yes, no. So, and I want to, of course, to encourage them as a maternal child health specialist, that I want to encourage them to do to that field. This is a field where part of my story is where you can go and save 2 lives with minimum effort. You save a mother and a child with a minimum effort if you do it right. So if you need to improve lives significantly, I would say go to maternal child health. You make a significant difference. I mean, if you save a pregnant mother, you save 2 lives.
I get
and
it.
you save 2 vulnerable lives that are desperate to need help. So if you do that, you will make a significant impact to your community.
Professor, do you have a story that has stuck in your mind about what you're just talking about? That you've saved those 2 lives?
Yeah.
I mean, and made you feel proud of the job that you're doing and you did?
I have several. I have always been doing several things. But one case that is stuck in my life, actually, I'm not the one who did it. It happened more than 20 years ago when I was a medical student. I was in my internship, so we used to have rotations in internship. For me, I used to ask my boss, the head of department, if I can volunteer to do just observe in the department on the weekends. You know, when we go in a hospital, when you are many, you don't have access to many patients. You are many students, there's one doctor, you all have questions, and so you don't have your own touch. And so I asked, can I come on weekend? They said, for sure. Then in the weekends, there's no competition. I am the only one, learner there.
Okay.
So I would volunteer and go on weekend. I go on this in the ward, it was in CHUB in Butare, and they brought a mother who was unconscious. They brought her on a stretcher at that time. And they said she has been in labor for 2 days at home, and it failed. They went to the health facility, and it failed, and now they bring her there. And the doctor said, is she alive? They said, we don't know. Maybe she's not alive. And so they brought her inside, and I went to help to lift to carry the mother from outside. The doctor came, examined, and said, oh, she's still alive, and made few exams on the womb, and said, oh, even the baby is still alive. He said, we have to rush to the health facility, to the operating room. I said, the doctor, can I assist? He said, sure. You can just observe, because I didn't know what to do. I just came in, and the doctor was so swift, did a cesarean section, called other team there, was an anesthesiologist and other team. He came, did a very quick cesarean, removed the baby, and the baby was alive, and the baby cried. And so they started resuscitating. Also, the mother gave fluids and so on, and this baby survived. They stayed in a hospital overnight, and in the morning, I saw the mother talking. It touched my life. At that time, I had not known about being a specialist, or I thought being a doctor just was enough. And so, I asked the doctor. He wasn't a gynecologist. He was an experienced general practitioner at that time. And so it touched my life that you can do a simple intervention and save 2 lives at the same time. And that was the story that made me be a gynecologist.
Oh, wow.
I thought, if you can do something. He did. I mean, it was under his hand. He did C-section, removed the baby, sutured, saved the mother, saved the baby at the same time. And I said, I think I have to be this.
Oh, wow.
That is how
so you believed in saving people.
I believed in saving people, and especially using minimum effort to achieve maximum results. Later, when I was, I think after my PhD, or slightly before, when I was doing a global health in the US, this story kept ringing in my head, and I told to someone, he said, how do you do it in Rwanda? I found I was doing most of these things, but I had forgotten about the case. They asked me the same question. I eventually published a paper.
The same question I've just asked you?
Yeah. I eventually published a paper called Achieving Large Ends with Limited Means. It became a big paper, and many policies.
Achieving
large ends with limited means.
Wow.
The paper is online, you can search on that. It means in maternal health, you can use minimum. I'm not saying people to use minimum effort, but I can say with the means we have, we can achieve significant results. Because it may only be education, just educating women on what to do and reaching out to them and encouraging them. That may be enough. It may be telling them to come for antenatal, educating them the importance of coming for antenatal, importance of vaccinating babies. That may be enough, and that effort we have. So if everyone does their best, we can already achieve significant results without going to finances, of course. Yeah. So when you add resources, you can do much, much more.
That is a very profound story that you just shared. I'm wondering, are you implanting this in the students you're teaching? Are you telling them to value saving the 2 lives you're talking about more than other factors that might be included or maybe considered by these professionals?
I try my best, of course, to talk to young people and encourage them to do this. And I think a few people have. And I'm always impressed whenever I travel, everywhere I meet students that I trained, and they are very proud of themselves, and they have become big people, and they are impacting lives in different ways. So, yeah, I think.
Okay. We are going for a short break, so you can have a breather, and then we come back shortly.
Thank you.